This is Dr. Robert Mitchell, who is going to tell us about liver cancer, the silent killer. Now, and Dr. Robert Mitchell is a gastroenterologist and liver specialist practicing at the Surrey Memorial Hospital in BC. And he has also an affiliated position with the University of British Columbia. And has special interest in viral hepatitis and also liver disease, especially liver cancer. So I would thank you. It's an honor to have Dr. Mitchell here to speak to us. And I'm passing on the mic to Dr. Mitchell.
Thank you very much. Can you hear me okay?
Yes, we hear you very well. Thank you.
Very good, very good. So thank you very, very much to the organizers for having me speak today about this important topic. And also wanted to thank the patients who are here and especially those patients who gave their stories earlier. Those were fantastic. I really enjoyed listening to those. So the topic that I've been asked to speak about today, which is also my clinical interest, is liver cancer. And the name of the talk is the silent killer. And I think I'd like to frame the talk. This is not intended to cause fear, although there is some scary aspects of liver cancer. This is intended to, inform. And I think in this circumstance, knowledge is power, especially as a patient living with chronic hepatitis B infection. It's helpful to know these things because you know then the right questions to ask your provider when you see them for your annual or every 6 months visit. So I have no disclosures that are relevant to this talk. I like to give this talk by sort of presenting a case that's unfortunately, a somewhat common occurrence, especially where I practice. I practice just outside of Vancouver, in a city called Surrey. And, being on call one day, I was asked to see a man, 65 years old, who knew that he had chronic hepatitis B infection. He was diagnosed many years ago. He was aware of his diagnosis, but as was mentioned, I think earlier by another speaker, felt that this was a carrier status and therefore had not been seeing active providers or having regular follow-up or testing. And unfortunately came into the hospital with a feeling of pain in his right upper part of the abdomen. And the doctor there in the emergency department did an ultrasound, which shows us this picture. This is what the liver looks like under ultrasound here, this gray area. And this slightly brighter area here, which is white, is a lump or a spot within the liver. So the emergency doctor unfortunately found this and calls me to come provide some help. So this talk is about what to do when this is found. So just framing the talk a little bit, liver cancer is unfortunately a leading cause of worldwide cancer death. We see that it is not the most common cancer. There are other cancers that are more common around the world, but the reality with liver cancer is that it's often picked up too late. And historically, our treatments have not been very good. They are getting much better, but this has led to a point where the mortality with liver cancer worldwide has been number 3 behind lung and colon. Around the world, the distribution and commonality of finding liver cancer is different depending on where we're looking in the world. And this closely mirrors how common hepatitis B occurs around the world, because hepatitis B is one of the main risk factors for developing liver cancer. So for example, in some parts of Africa and Asia, we see high rates of hepatitis B infection indicated here by the large part of the pie graph, which is orange. And we also see that the rates of liver cancer in these areas are very high, indicated by the darker blue color. So we see that the worldwide incidence of liver cancer closely follows the worldwide incidence of hepatitis B, which gives us a clue as to what the main risk factor here for liver cancer is, and that's hepatitis B. So we know from studies over the years who is at risk for liver cancer. I would say that in the general population, so those who do not have underlying liver disease, the risk of liver cancer is quite low. But we know that it is increased in anybody who has a scarred liver or a cirrhotic liver from any cause, whether that is alcohol, hepatitis C, fatty liver, hepatitis B. But we also know that in people who have chronic hepatitis B, so this is definitely true in people who have surface antigen positivity, there is an increased risk of liver cancer, even without cirrhosis. Okay. We know that taking antiviral therapies for hepatitis B will reduce this risk. And this was commented on earlier also by Dr. Coffin, and I wonder maybe some of the speakers this afternoon will speak about this as well. But this is one of the major reasons to treat hepatitis B, is that this is actually reducing our cancer risk. So taking antiviral therapy, if you do not have cirrhosis, may reduce your risk of liver cancer by up to 30%, depending on some other variables. And if you do have scarring or cirrhosis in the liver, taking those antivirals may reduce your risk by up to 80% of getting liver cancer. One important comment to make, however, is in some situations, even if you are taking the antiviral and you have chronic hepatitis B infection, the risk of eventually developing liver cancer might be high enough that screening for liver cancer should be considered. And so when we're looking at when should we screen for liver cancer, we go back to look at, well, who is at high risk for developing liver cancer, okay? And for hepatitis B, we say that generally speaking, for men above the age of 40, whether or not you're taking an antiviral, you should be screened for liver cancer. For women above the age of 50, whether or not you're taking an antiviral, you should be screened for liver cancer. Persons who are from Africa at an earlier age with hepatitis B should be screened for liver cancer. In my practice, I start screening immediately as soon as I meet these patients, regardless of age. And then anybody who has chronic hepatitis B infection and has a family member who has liver cancer should be screened, regardless of their own age, okay? Now, there's a comment here about endemic country. I think many of us maybe are practicing more generally based on this age recommendation, regardless of the country of origin. But I know that that is a bit of a controversy, and some people may practice differently than others in this regard. Now, how do we screen for liver cancer? So right now, our best screening test is a combination of imaging and blood work. And for most people, the type of imaging that we would use is an ultrasound, okay? And so this is, again, what the ultrasound picture looks like. The ultrasound is a non-invasive test. I bet many people in this audience and people speaking have had an ultrasound for one reason or another. You'll know that it's not a painful test. It's a probe that's, in this case, put over the right upper part of the abdomen. We get a good look here at the liver. And if a lump happens to be in there, it'll be often brighter than the rest of the liver. So ultrasound is one test that should be done, and it should be done every 6 months if you're in those risk categories by age and hepatitis B status or family history. These days, most doctors, again, not everybody, not all doctors will be practicing this way, but many liver doctors and providers will also be adding on a test called alpha-fetoprotein, which is a blood test, and this is considered a tumor marker. It's secreted by liver cancer cells, and using this test every 6 months, in addition to the ultrasound, will make it more likely that your provider will be able to detect an early liver cancer than if they don't do this test. So these days, many providers will also add on this test or request that this test be done every 6 months if you're in a risk category where screening is indicated. One thing I'll say, especially for those who are able to check their lab work, I know here in British Columbia, patients are thankfully able to see their labs online. Alpha-fetoprotein is a tricky test. It's not a perfect test, and sometimes it can be a little bit elevated. And it's important, if it's flagged as being elevated or you see your test come back elevated, to review that with your provider. May not always indicate that you actually have a cancer, anything to be worried about. And oftentimes your doctor may look more at the trend of this number, meaning how much it changes over time. A few words just on the ultrasound, because this is something that many of my patients experience and many patients in this audience may experience, which is that it is a good test. It's probably the best test we have right now on a population level to screen for liver cancer, but it's not a perfect test. And here you can see a very good ultrasound. We see the whole liver, okay? And in these other panels, we see some circumstances where the ultrasound, for whatever reason, can't see the whole liver. Here, there's a rib that's getting in the way. And here are people who have a little bit of extra fat in the belly, and it creates some problems with the ultrasound. The ultrasound uses sound waves, and sometimes a little bit of extra fat in the belly makes it harder to see the whole liver. So these three panels here show us a case where the ultrasound can't see the whole liver. Now, obviously, that's a problem because we want to be able to see the whole liver in order to detect liver spots. And we know that, some estimates say that maybe about 7 or 8 in 10 ultrasounds do a good job of seeing the whole liver and are adequate to screen for liver cancer. Okay. But this means that 2 in 10, 3 in 10 times, you may get a call from your doctor saying, you know what, we could not quite see the whole liver on your last ultrasound, and we have to order another test. And that's very common. I want to sort of emphasize that is not necessarily cause for alarm, right? It just means that your doctor is wanting to get a better look at the whole liver. And in that circumstance, they might order a different test called a CT scan or an MRI, just to see the entire liver and make sure that nothing at all is missed. Now, another important point is that not every liver lump that's detected on ultrasound turns out to be liver cancer. And in fact, most of the things that are found on ultrasound, thankfully, do not end up being liver cancer. There are a few other benign or non-cancer spots that we very, very commonly see. One is called a hemangioma, which is extremely common. That's like a collection of blood vessels that can form within the liver, often at birth, and can grow as we get older, but have no potential to cause harm or spread to other organs. So we don't consider those to be a cancer. There are other things called nodular hyperplasia or adenomas, which are also benign, something that your doctor may order other tests to further investigate, but ultimately are not concerning. Liver cysts are another very common finding. Those are like fluid collections that can form within the liver. And focal fat infiltration, another very common but benign finding. And then, of course, we have our more concerning findings, the cancerous lesions like liver cancer. You can also have cancer spreading from elsewhere. We call that metastases to the liver. So when your doctor does find a liver lump on the ultrasound, they will order another test. It will either be a CT scan or an MRI. And this is done because CT scan and MRI is an excellent test in order to distinguish between liver cancer and what are more benign liver spots. And usually we can get a diagnosis about the true nature of these liver lumps just by doing a CT scan or an MRI. Usually is not needed to actually do a liver biopsy. And this takes advantage of a very unique aspect of the blood flow to the liver. Liver is a very fortunate organ. It gets 2 supplies of blood. And our imaging takes advantage of this aspect to give us a very good sense of what these liver spots are on a CT scan or an MRI. So this is often the next test that your doctor will order if they discover a lump on the ultrasound. Now, this part's just a little bit technical, but I share this because you may hear your doctor speaking in this language. We always try to speak in plain language, but I know, some patients may hear this terminology from their providers, right? And so after a CT scan or MRI is done, your doctor will attempt to assign a risk score to that finding on CT scan or MRI. And this is called a LIRADS score. And a LIRADS score that is higher indicates a higher likelihood that that spot is liver cancer or HCC, whereas a lower score is less likely to be liver cancer. And what your doctor will attempt to do is categorize the spot into one of these risk scores, only by using a CT scan or MRI. We do this because we know that assigning these risk scores gives us a very good sense of what that liver spot will ultimately end up being and how concerned we have to be about that liver spot, okay? And doctors will often gather as a group called a tumor board in order to make this determination, okay? So this is a rounds where your provider can speak with experts who are radiologists, who are experts at looking at these images in order to assign this risk score, which in turn tells us how worried we have to be about these liver spots and ultimately what we have to do next to proceed with your care. As I've been mentioning, we can often get a very good sense about what these liver spots are only by doing non-invasive testing like a CT scan or MRI. But sometimes there's still some uncertainty after these scans. And this is where your doctor and the tumor board may order a liver biopsy. Something that's a little bit different about liver cancer compared to other liver cancers is that we don't need the biopsy. And very often we don't do the biopsy at all. And this is, again, speaking to how good the CT scan and MRI are at making the diagnosis. We only do the liver biopsy if there's true uncertainty about the nature of the liver lump. And liver biopsy is a safe procedure, right? But A, it's often not needed, and B, every procedure and intervention in medicine comes with small risks. And in this case, if we can avoid the risks, of course, we'd like to avoid them. So this is why a liver biopsy is not always ordered if there's concern for liver cancer. Now, when it comes to how we stage liver cancer, this is also very, very different from other forms of cancer. And this is often one of the first questions that my patients will ask when we make this diagnosis. What is my stage? We often hear about a stage 1, 2, 3, 4 with other cancers. In liver cancer, it doesn't quite work like that because the liver is a very unique organ, right? It plays such an important role in the overall function of our body. We're not only looking at the number of tumors, the size of tumors, or whether those tumors have spread. We're also looking at how well is our liver functioning and how well is the patient doing overall, right? But based on this, we will assign a stage, and we usually speak in plain language when it comes to the stage of liver cancer. We might say very early, we might say early, indeterminate, or intermediate, advanced, or very advanced palliative. So less so the numbers 1, 2, 3, 4, more that plain language kind of staging. Now, when it comes to the treatment of liver cancer, the treatments are very complex and often individualized to the patient. But some of the treatments might include surgery, especially if it's just one area of cancer and it's a very small area. The surgeon might be able to cut it out and get a very good result from that. These days, we also have something called ablation, which is when a probe is used from outside and can treat the tumor with a high amount of energy, often using heat or microwave to burn away the cancer cells. And again, this is often done in cases where the area of tumor is very small, and we feel that this will be a good, effective way of treatment. We have a technique called embolization. And what this means is starving the blood supply that goes from the body to the tumor. So embolization means placing these little clots. And often these are synthetic, they're made in a lab. These days, we can coat the clots with chemotherapy or radiation, which not only starves the blood supply to the tumor, but also delivers a direct dose of radiation or medicine that will treat the cancer cells and shrink them in a very targeted way. So it will affect the cancer cells, but not the rest of the healthy liver. We also have more conventional radiation that can be applied from outside of the body. or more conventional chemotherapy that can be given through an IV and can affect tumor cells that maybe have spread outside of the liver to other parts of the body. And finally, a big part of liver cancer treatment these days is actually liver transplantation. And that is trying to identify cases where, perhaps the amount of tumor within the liver is too much to treat with these methods. And in order to get a good cure and a good result with long-term health, we may actually need to remove the diseased liver and place a new healthy liver from a donor. So in practice, the point I'll make sort of as we round out the talk here is that when it comes to the treatment, it's extremely complex, and it's common, these days for cancer treatment to be this way. But I would say that liver cancer is on the way more complex end of the spectrum compared to other forms of cancer treatment. And so the modern treatment of liver cancer involves many different individuals. It involves a team of doctors, and it involves these multidisciplinary tumor boards where all kinds of different doctors get together and try to determine the best treatment path for the individual patient. And I think, a point that I'll make is that this is a good thing. I often get a response from my patients when I say, well, we've made the diagnosis, we're going to present this at tumor board. This is a positive thing, bringing other doctors into the fold and having a team-based approach to this. And we actually have research studies that tell us if we do this team-based approach for liver cancer, we get better outcomes. So we'll go back to our case just to kind of demonstrate the patient journey here and what can happen next after this diagnosis is made. So again, we had a 65-year-old man. He was aware of his chronic hepatitis B infection, but perhaps was not aware of the need for screening, had not been started on antiviral therapy, and unfortunately came into my hospital with abdominal pain. And we had the ultrasound done here, which showed this liver lump, right? So the next test that I ordered was the CT scan, right? And the CT scan shows us some areas here and here where there's unfortunately what looks like cancer involving the liver. So I brought the case to our tumor board. I made sure that we had agreement amongst all of the special doctors who look at images, called radiologists, all of our cancer care team, that yes, this looks like liver cancer. So we did not need to order a liver biopsy to make the diagnosis. We felt confident in the diagnosis just based on the CT scan to proceed with care. Now at that meeting, we also talked about what our goals for treatment are. And we talked to the patient about this as well. And we say, well, we want to get you to a cure. We want to get you, living a very long and healthy life, despite making this diagnosis. And I'll round out here today by just showing an example of the path that this can take for one patient. So this patient's case was presented at this multidisciplinary tumor board, and we said, well, there's quite a bit of cancer in that liver. We think the best way that we can get a cure is actually getting our patient to a liver transplant. So to start with, they were started on a chemotherapy called lenvatinib. That's a medicine that goes in through the IV. And we see how our patient does, when we notice that after being on this therapy for a few months, the tumor's not growing, it's not changing. So let's apply another treatment to that tumor to try to shrink it down. And this is that embolization, the targeted blood clot, giving radiation directly to the tumor. Now this was done, there was a very good effect from that. It shrunk the tumor down nicely. In the background, the hepatologist is giving treatment for hepatitis B, and we're getting a transplant workup started. There's some speed bumps along the way, but ultimately we get our patient to a liver transplant and they have an excellent outcome. So I say this to highlight that this can be a long journey. There's a lot of different doctors involved, some speed bumps along the way, but I think we've gone from a place maybe 15, 20 years ago where receiving this diagnosis was very bad news. And it still is bad news. I won't minimize that, but to a place where our treatments have improved, our outcomes are getting better and better. and we can often live a very long and healthy life after this diagnosis is made. And so I wanted to thank you for your attention and for inviting me to speak today.